Hello, I'm Professor Dayan from the Cardiff University School of Medicine, and it's a pleasure to talk to you today about barriers to insulin therapy in type 2 diabetes. So as you'll know, there are lots of different types of insulin, and the issues of the problems with insulin therapy are very dependent on the type of insulin that's going to be used. In a later lecture, they'll go into this in a little bit more detail, but I'll come back to the issues related to certain insulins later in the talk. So here are the main list of barriers to insulin therapy. I'm going to talk a little bit about alternative therapies as well as combination risks. So the position of insulin seems to be gradually changing in the hierarchy of treatments for type 2 diabetes, and there are also certain combinations that don't work as well or maybe carry additional risk when you're planning insulin therapy. Weight gain is a major concern to patients with type 2 diabetes because they're overweight to begin with. Hypoglycemia, however, remains the major concern both for the physicians and the patients. And then the last three, fear of insulin injections, physician inertia, and support services are an issue, but mostly we can get around those issues depending on the healthcare setup that you have. So here is the IDF algorithm for treatment in type 2 diabetes, as always starting with lifestyle, and it's really important to mention and emphasize that lifestyle measures, as the arrow on the left hand side indicates, continue right through all the other treatments. So the weight gain with diabetes is going to be less if you have active exercise, reduced calorie intake, good lifestyle measures. So nobody disputes the fact that the second treatment is metformin. However, there is some debate about what the third treatment should be, whether that should be sulfonylurea or one of the newer agents, as you see here on the fourth line, or the third line it's referred to as, adding in a DPP-4 inhibitor or a thiazolidine or GLP-1 agonist. And in fact, in this version of the algorithm, it doesn't include the gliflozins, dapagliflozin, canagliflozin, the SGLT2 inhibitors. And they're becoming an important factor in planning when to start insulin, because all of these agents can be combined with insulin, and we may need to think about those things when we look at the barriers. And then finally, at the bottom of the line here was basal insulin. And this has changed so dramatically in the last 5 to 8 years, when it was always the steps were insulin would be third line, metformin, sulfonylurea, and basal insulin. And in the American guidelines, insulin is still higher than in the IDF guidelines. So talking a little bit about alternative therapies, you'll be aware of the use of GLP-1 therapies. And what I wanted to illustrate here in this diagram is on the left you see exenatide, which is a GLP-1 therapy, and on the right you see insulin glargine. And so the top open symbols are before therapy, and the bottom one is after therapy. And both of the treatments result in the same drop in HbA1c. But you'll see in the insulin glargine on the right, you've still got the variability in glucose levels that you had before starting the insulin. And you're exposing yourself to more risk of hypoglycemia and postprandial hyperglycemia. Whereas with exenatide, it irons this out, and you see that with all the GLP-1s, so you get a flatter profile, meaning you get less postprandial high levels and less risk of low levels. So if you were to look at both of those things, you'd probably say, well, I'd prefer the profile on the left than the profile on the right, and it is for that reason that increasingly people are using things like the GLP-1 analogs before considering insulin. What about combinations? Well, here's a recent study by Mogensen. It's a retrospective study looking at a large population in Scandinavia. And what it's trying to show you in A, the all-cause mortality, or in B, the cardiovascular mortality, you're seeing lots of different sulfonylureas, but if you look at the bottom line, the SUs combined, which is combining all this information together, it's indicating that in their retrospective analysis, patients who took sulfonylureas and insulin together had a higher all-cause mortality and cardiovascular mortality. Now it's important to realize that doesn't mean to say that sulfonylureas caused the problem, because it could be that they were on it for a different reason, or they had difficulty taking other medications, etc. But it's certainly a warning that probably we shouldn't combine those, or consider carefully whether we're going to continue sulfonylureas when we begin insulin. And in general, I do stop the sulfonylurea when patients begin insulin. And in some countries, there's an increasing use of bariatric surgery. here's the various procedures that are used for bariatric surgery. And what I'm showing on the next slide here is that actually that often results in remission. So instead of people having to go onto insulin, they actually become medication free, and many people who are actually on insulin therapy can come off insulin therapy after bariatric surgery. So again, that changes our threshold for use of insulin. On the bottom is some data from our own laboratory showing in the change in insulin sensitivity and measured by two different means as people undergo bariatric surgery, so they're from the open symbols up to the closed symbols. But what you're seeing here, the closed symbols on the top is showing lean individuals, on the bottom is the obese individuals, and that's after their bariatric surgery. You see a move on the bottom line, a move of the curve to the left, which means they become more insulin sensitive. But they never become as sensitive as the lean individuals. And so what that's saying is, although bariatric surgery might prevent insulin or get you off insulin, if you put the weight back on, you will be back to the position of needing additional therapies such as insulin. So it's not a permanent therapy in that regard. That leads me on to talking a little bit about weight gain. And insulin is one of the few therapies that does increase weight when you use it for metabolic control. So here again is a comparison of exenatide versus insulin, and you can see the weight gain with insulin glargine, the weight fall with exenatide, even though they achieved a similar HbA1c. So ending up with a 3 or 4 kilo difference after 26 weeks. Now, there is evidence that certain combinations result in less weight gain. For example, adding metformin in, and here's one example from Iki Järvinen that shows that keeping your metformin or adding the metformin in along with your insulin can result in less weight gain, probably by around 1 kilo. And the regime you use for treating patients, the insulin regime, can also affect the weight gain, but it seems that that's predominantly to do with the tightness of the HbA1c control. So here's the well-known 4T study, and this slide explains the different therapies, and it's a bit busy, but essentially people were randomized, if you look on the left-hand side, to either basal insulin, bottom on the left, or prandial insulin, or biphasic insulin. And then if they didn't respond well, they had additional therapies added in. So if you go on to the next slide, which is perhaps a little small, but what you can see in the top left-hand graph is you see 3 lines, red, a sort of greyish line, and light blue. And these are the different insulin therapies. And what it's showing you is HbA1c over time. You'll see that the blue line, which is in fact the prandial insulin, most rapidly gained control, but eventually after a few years they ended up with the same HbA1c. But the basal insulin had slightly less improvement in glycosylated hemoglobin initially. So when you look in the in box C, that's the middle on the left, you see the weight gain, and you see that the basal insulin appeared to result in the least weight gain as opposed to the biphasic or prandial insulins. But putting that all together, it looks like probably that's because you received overall less tight glycemic control. So the tighter the glycemic control, the more weight you gain. And largely this is because you retain the calories. Now there are ways of combating this, and very recently studies have begun to combine GLP-1s and insulin to get the benefit of both, and it does seem to work. So here, for example, is a randomized trial of liraglutide, another GLP-1, and a particular insulin degludec. Again, I'm afraid a busy slide, but let me talk you through it. So in the top left-hand corner, you see in the dark blue, you see individuals with just the insulin, so IDEG, and then in the light blue, the addition of Lyra. So you're seeing a better HbA1c drop when you add in the GLP-1. And if you move to the right-hand side and you move 3 down to the panel F, you can see the body weight change. And remarkably, with the Lyra, you actually see a weight gain drop of 2.5 kilos. With the insulin, it's neutral. So what you're seeing is an improvement in HbA1c and still a drop in weight by the combination of the two together. And then if you look in the top right, you see panel B is change in HbA1c you see you're getting a better drop with the combination of GLP-1 and insulin. So putting all this together, what it's saying is that if you do half the job with insulin and half the job with a GLP-1, you get the weight loss that you wanted as well as improved HbA1c. So I think this is probably going to be a direction for the future. Okay, now we need to talk about hypoglycemia, which is the most feared complication. A lot of this data comes from type 1 diabetes, where hypoglycemia is very frequent, but I'll also touch on data from type 2 diabetes. Now this slide is probably the most important slide. It's the oldest slide, but what it is showing you is from the Diabetes Control and Complications trial, which is a type 1 diabetes trial, comparing HbA1c along the bottom to rate of hypoglycemia up the left-hand side. And as you might guess, the tighter your HbA1c, the lower it is, the more hypoglycemia you get. And it's very important to bear this in mind when you're trying to choose a target. So if you're starting somebody who's over 80 years old on insulin to control their glucose, you may not want to aim for such a tight control. You may be aiming for example, 9%, when the rate of hypoglycemia is going to be a lot lower than if you aim for 6%. And at that age, the risk to the patient for retinopathy is much less than the risk of a hypoglycemic event, falling over, having a subdural hemorrhage, or a fractured hip. So why is hypoglycemia so frequent with insulin compared to the other therapies? And this is because it doesn't match the endogenous profile. So this is showing you here time in hours of what would happen if you have an intact pancreas is in red, so you release the insulin very rapidly and then it's gone very rapidly after the meal, whereas injected insulin builds up much more slowly. Even with ultra-fast insulins, the rate of rise is too slow, and then after the meal it hangs around for too long, giving you the risk after 2 or 3 hours of hypoglycemia. And we're particularly concerned with the pathophysiological and cardiovascular consequences of hypoglycemia. This slide is showing many of them, but at the bottom is activation of sympathoadrenal response and adrenaline, which has a risk of driving arrhythmias and hemodynamic abnormalities. There's evidence that hypoglycemia can drive inflammation on the top there. On the right-hand side, endothelial dysfunction, and on the left-hand side, blood coagulation abnormalities. So if you add all of those things together, you're going to increase your cardiovascular risk if you get recurrent hypoglycemia. And that's not so much of a problem in a young person with type 1 diabetes, but in an older individual already at risk because of type 2 diabetes for cardiovascular disease, giving a drug which increases your risk of cardiovascular disease by hypoglycemia is a concern, and equally the weight gain also. So in other studies, now the ACCORD study here is not specifically insulin therapy, but what it's showing you is that intensive treatment results in higher adjusted mortality, and particularly this is seen when there is more than one severe hypoglycemic episode. So in the dark blue, the effect is most dramatic when people are getting hypoglycemia. So there's much concern that this is evidence that hypoglycemia is indeed associated with mortality and cardiovascular events. And here is another recent retrospective study looking at over 860,000 individuals, looking for associations between hypoglycemia and cardiovascular events. So 79% higher odds of acute cardiovascular events in patients who have hypoglycemia. So if you're going to tighten up and give people hypoglycemia, it's not just falling over and the risk in elderly people of hip fractures and head injuries, but an increased risk of cardiovascular disease behind this. So it's not just unpleasant for the patients, it may be very dangerous for them also. Now you've got to set this against the fact that there's what's called a legacy effect of early glucose control. So the tighter you control people's glucose, the longer effect you get. In other words, if you aggressively treat them for the first 10 years, and this is from the UK PDS study, so 1997 was in the at the end of the intensive therapy time, and 2007 was the time of the follow-up. And what the percentages are showing here, or the relative risk reduction, is showing you for those who had intensive control, for example, any diabetes-related endpoint, there was already a 12% reduction, but 10 years later there was also a 9% benefit even though for those last 10 years there was no difference in glucose control. And equally and particularly, if you look at microvascular disease, the benefit of a 25% risk reduction persisted 10 years later. From having good control in the first 10 years, you got a benefit even though there wasn't tight control in the subsequent 10 years. So this is the challenge. You want tight control for long-lasting effects, but the tight control, particularly with insulin, exposes you to the risk of hypoglycemia. So patients with type 2 diabetes experience much less hypoglycemia than type 1 diabetes, but this is a graph just showing that it is significant. And if you develop hypoglycemia, particularly on sulfonylureas, but also on insulin, this can result in admission to hospital. So it's pointing out here, severe hypoglycemia is the most frequent acute complication needing hospitalization. And in terms of the costs of managing a patient, over 50% of the costs are time spent in hospital. So there are many, many reasons for the patient, for their survival, their cardiovascular risk, and for the cost that we want to reduce hypoglycemia. Just a little bit about hypoglycemia itself, and now we're showing the values in milligrams per deciliter, but showing a pyramid that you're probably familiar with, that as the glucose level falls, first insulin is switched off, then you get a counter-regulatory response, now around 70 milligrams per deciliter, increased glucagon, adrenaline or epinephrine, as well as ACTH, cortisol, and growth hormone, all of which are trying to push the sugar back up. And that's associated with a feeling, and definitely felt by 50 milligrams per deciliter, of palpitations, sweating, what the patients recognize, a lot of which is due to the adrenaline response. And then further down, if they don't notice these symptoms, or if it persists, they start to get confused, aberrant behavior, decreased cognition, and lower than that, seizures and coma. And if it's prolonged and even lower, they eventually can get brain damage or neuronal cell death. Now, not surprisingly, the patients don't like severe hypoglycemia, and so this is it's a questionnaire showing their worry about it. So in patients who've had severe or very severe, we often categorize that as an episode when you've needed help from a third party. So in those situations, the patients are very anxious. So the scale on the left-hand side is their level of anxiety from the hypoglycemia fear survey. If they've had severe or very severe hypoglycemia, they're very anxious about hypoglycemia and will not want to have intensive insulin therapy. And again, if they've had any hypoglycemia, their fear of hypoglycemia increases. So this is just showing you that in patients who have experienced it at least at one occasion, they're almost twice as fearful of hypoglycemia as those who've never experienced it. So it is a very disturbing experience for patients, and one that they will lead them to want to avoid hypoglycemia as much as possible. And as a result of that, they stop taking their insulin. So what you're seeing here is fear of hypoglycemia reduces patients' adherence and may affect their glycemic control. So 58% of people experiencing severe hypoglycemia modify their insulin dose to avoid future hypoglycemia. And you might think that's sensible, which it probably is sensible to do, but it will result in them achieving less tight control. And it's showing you both type 1 and type 2 diabetes. So if you get recurrent hypoglycemia, which is much less common in type 2 diabetes, but it does result in hypoglycemia unawareness. So that means you don't feel the response and you don't notice it. Again, a slightly busy slide, but what it's trying to show you is that even after one hypoglycemic episode created in the laboratory here by Simon Heller and colleagues, you see on the left-hand side, the dark blue, a drop in adrenaline, and on the right-hand side, the light blue, a drop in the symptom score when they get a second episode of hypoglycemia. So they're getting less adrenaline response the second time around, and less symptoms the second time around. I put also there that the glucagon response is also lost after recurrent hypoglycemia. So we often say hypos beget hypos. In other words, the more you get, the more you get, because the more hypos you have, the less reaction you have, so your sugar falls more rapidly, and the less you feel them, so you notice them less, so you get more because you can't avoid them at an early stage, and they're more profound. So it's a bit of a vicious cycle. And even without lots of severe hypos, many hypoglycemic episodes go unrecognized. We were familiar with this in the past with children having hypos at night that were unrecognized. But now CGM monitoring here is illustrating even in type 2 diabetes, if you look on the right-hand side, that a very high number of blood glucose readings go unrecognized, and that also happens during the day. So almost all of the ones that occurred were unrecognized at night, maybe because you were asleep and you didn't wake up, and during the day it's over 50% are unrecognized when you do continuous glucose monitoring. And it does seem that as you get older, you have it also affects your threshold for feeling the hypoglycemia. So on the left-hand side is showing young men and their threshold for perceiving the hypoglycemia, saying I have got symptoms, whereas in the older men aged 65, they had to get down as low as around 54 before they actually had any symptom perception of the hypoglycemia. So this impaired counter-regulatory defenses and impaired awareness, which go together of hypoglycemia, are worse with long duration of diabetes, tight glycemic control because of recurrent hypoglycemia. We've shown you increasing age. It can be affected by sleep and exercise because you don't detect the hypoglycemia during those two activities, and possibly by the use of beta blockers and alcohol as well. So finally, in the last couple of minutes, looking at the last three issues: fear of insulin injections, insulin, and insulin itself. The fear of insulin does exist, and for many people is built around the hypoglycemia and the weight gain, but also because it was used as a last-ditch therapy. So people say, oh, my mother died when she went onto insulin, and it wasn't because of the insulin, it was because she got so far into her disease that it was, if you like, a final therapy, but not really an effect of the insulin itself. Actually, although people are fearful of the injections, I usually say to them, well, look, if you can test your blood, do your finger pricks to test your blood, it's much less painful than that, and they find that is the case. So then the fear of injections becomes quite a bit less. This is a slide to show you physician inertia. For all the reasons we've just been talking about, people delay the use of insulin, and it's deliberately there to show that in Egypt subgroup, the HbA1c at which people started insulin was around 9%, which is similar to across Europe and in many of the other studies just shown. And so there was an HbA1c was high when they started it, and there's also a diabetes duration of many years, between 8 and 10 years, before people are starting insulin therapy. Finally, this graph is trying to show you the approach of group versus individual education. So there is a problem about having enough people to start all your patients on insulin, and there's the concerns of the individual. And what's been illustrated here is that sometimes you can get around this by having groups, so bringing people together to start insulin together. That requires less time of the healthcare professional, and it means it gives people reassurance and they can talk to others at the same time. So yellow is individual starts and green is group starts. What it's showing across the top is that the satisfaction is the same, top right, and the HbA1c achieved is the same between individual and group starts, but top left, there's actually less visits and less phone contact overall, and less time taken in these activities, almost half the time when you do it as a group. So the target was reached in 70% of these individual cases, and group education was very cost effective, so that's certainly worth considering. So to summarize, alternative therapies with less hypoglycemia and weight gain are delaying the place of insulin. Weight gain and hypoglycemia is related to the intensity of control, so depending on what the target you're setting for an individual, and we want a lower target for younger individuals and a higher target maybe for older individuals. Weight gain, however, may be offset to some degree by combination therapies such as with GLP-1s. Hypoglycemia is the most feared complication, but physician inertia to accelerating therapy towards insulin persists. And we may want to think about that differently, as we're now having younger and younger patients coming to the end of the line with their therapies and beginning to think about insulin. And for those individuals, we really need to get over that physician inertia so they get the benefit of the legacy effect of early, tight glycemic control. Thank you.